Thank you, Chairperson Sir, and all seniors and dear colleagues present here. At the outset, I'd like to thank Pratapda for the kind invite and Rutul also for the kind invite, and being the first batchman, I'm a little tensed, but so I'll be talking about MASLD, type 2 diabetes, cardiovascular, crosslink and connections. No disclaimers. So the agenda will be trying to understand what is MASLD. This is a new terminology. Previously it was NFLD, and we'll try to understand the crosslink between MASLD, type 2 diabetes and cardiovascular disease, and clinical importance and screening recommendations when to screen for MASLD, because it's a very rampant I'll say disease, but screening is not done as much. And if time permits, some diagnostic algorithms and how to manage it. Is this connected? So previously, as I mentioned, it was called NFLD, and in June 2023, 56 countries and 236 panelists worldwide, they discussed about this new terminology, and they put forward the change of terminology, because non-alcoholic or fatty liver, these are things which is sort of stigmatizing. So they felt that if we change that to MASLD or steatotic liver disease, if associated with any other metabolic disorder, then it is called MASLD. And the new term hence was given as metabolic dysfunction associated steatotic liver disease, which comprises of steatotic liver disease, which is, if fat in liver, more than 5% fat is there in liver. Apart from that, if any one of the following is there, cardiometabolic risk factors, if any one of them is present, then it is called MASLD. And it may be elevated triglyceride or low HDL. It may be type 2 diabetes or obesity or high blood pressure. If any one of them is present along with 5%, more than 5% hepatic fat, then it is called MASLD. So that change in NFLD to MASLD happened in June 2023. So what is the metabolic triad? MASLD, type 2 diabetes and cardiovascular disease, because these are three entities which share overlapping pathophysiology, and because of which all is interlinked. And if one is there, then chances of having the other is also there, and chances of having comorbidities associated with each of them increases. And it is seen that MASLD can affect up to 25% of the adults, and it's more commoner in type 2 diabetes, around 70% more associated with type 2 diabetes. If someone is having MASLD, cardiovascular disease is one of the leading causes of that. We'll get to see in the subsequent slides that there are a vast gamut of cardiovascular ailments which can happen if someone has MASLD. And chances of MI, stroke and cardiovascular event increases by 1.5 to 2 times if someone has MASLD along with type 2 diabetes. So what is the interlink between all the three? Insulin resistance is one of the main causes or strong interaction that associates all the three, MASLD, diabetes and cardiovascular disease. We know insulin resistance can be at the level of the adipose tissue, skeletal muscle, at the level of the liver also. And that leads to the formation of the metabolic derangement which happens, and also cardiovascular disease which can happen if someone has diabetes. If someone develops MASLD, that's the precursor for development of fibrosis or MASH, and ultimately leading to cirrhosis or HCC. Overall, if we try to find a link, it is the insulin resistance. Helped by the environmental factors or genetic predisposition, diet, gut microbiota, all these things ultimately affect if someone develops insulin resistance, and it may go into development of NFLD or MSLD at the level of the liver, or also leading to type 2 diabetes mellitus. And how that insulin resistance affects is that in the level of the liver, it will cause increased gluconeogenesis, decreased insulin clearance, circulating insulin levels will increase, and thereby the insulin resistance, what we say that if more quantity of insulin is required to suppress the gluconeogenesis, then it is called insulin resistance. De novo lipogenesis increases, free fatty acid increases, and all different types of inflammatory cytokines, which ultimately leads to the development of the cardiovascular disease, and also the increased TG, the oxidative stress, LDL, and decreased HDL. These are the factors which affects the development of diabetes also and cardiovascular disease. So if one has type 2 diabetes, so if one has type 2 diabetes, a lot of interlink is there. Main per se is the insulin resistance, which affects the organs, various organs, and we can see that all the three compartments are interlinked. And if someone has type 2 diabetes, there are chances of having cardiovascular disease. Around 32% of the type 2 diabetic patients suffer from cardiovascular disease, and again 47% of the MSLD patients also have coronary artery disease. So these three entities are interlinked to each other and leading to various gamut of cardiovascular ailments. If you can see the the percentage of various cardiovascular ailments which can happen if someone has MSLD, starting from increased chances of MACE, peripheral artery disease, ischemic stroke, cardiac arrest, CKD prevalence, increased risk of MI, atrial fibrillation, a lot of things, cardiac ailments happen definitely because of the MSLD, which is seen in different percentages you can see in this particular slide. So we can see that it is affecting a lot of organs, and it's a silent killer. But why is it important? Because if someone has MSLD along with type 2 diabetes, the risk for cardiovascular disease increases phenomenally. And definitely we need to do early intervention to reduce the progression of the disease and to decrease the mortality. What the ADA, AASLD recommends is that annual MSLD screening for type 2 diabetic patients. Different organizations have different screening recommendations, but all of them in fact recommend screening for MSLD. We'll try to see what type of screening modalities are available. In this particular paper, what they looked into is that chances of clinically significant liver fibrosis as measured by transient elastography, fibroscan, due to non-alcoholic fatty liver disease in Indian individuals with type 2 diabetes mellitus. They looked into 603 consecutive type 2 diabetic patients. This is a paper from Kolkata, and it was seen that around 58.9% of the participants had hepatic steatosis. If you screen consecutively type 2 diabetic patients, you can see that the association of fatty liver disease is so prevalent, 58.9%. That's in from eastern part of the India. And AST-LT was increased in around 27.7% of the patients, and around 37.2% of the individuals had clinically significant liver fibrosis. So that's quite huge. Another paper from Japan which looked into two different types of things. One is type 2 diabetes and MSLD, and related steatotic liver disease status with the risk of developing cardiovascular disease. And what was seen is that if someone was non-diabetic, if someone is diabetic and they underwent remission, then they were positively affected. I mean, all the parameters were improved. That means the liver fat and all the parameters improved, and cardiovascular benefit was there, around 35% improvement was there. But if you see someone is non-diabetic and MSLD, they developed diabetes or increase in the MSLD happened, then the significant increase in the cardiovascular risk. So that we need to understand that it's a disease which is prevalent very much in, amongst us, but we need to screen them. What proper methodology for screening we have to adopt it, not just the liver enzymes, but some other methods are also there which we need to include in our routine care, and we have to screen. AASLD recommend that if someone has type 2 diabetes, then we need to screen. EASL, EASD, and EASO recommends that if someone has type 2 diabetes or obesity, plus one or more of the cardiometabolic risk factors are there, then we have to screen. ADA also recommends that if someone has type 2 diabetes or pre-diabetes with obesity, then we have to screen. And also with type 1 diabetes, if they develop obesity, then we have to screen for fatty liver disease also. FIB4 is a very easy method of non-invasive way of screening for liver disease, mainly the fatty liver disease or fibrosis. And it's based on 4 parameters: age, AST, ALT, and platelet count. And cutoffs are, age group is 35 to 65 years. Beyond 65, the lower cutoff will be a little higher, but within that 35 to 65 year age group, the lower cutoff is 1.3. And if less than 1.3, then it's said that fibrosis or fibrosis is not there, it's ruled out. If it is between 1.3 to 2.6, then intermediate fibrosis is there, then we need to go for other modalities of checking also. And after FIB4, confirming with FIB4 scoring, if we find there is intermediate or moderate fibrosis is there, then we have to screen by fibroscan, which is a vibration controlled transient elastography. And there we look into 2 parameters. One is liver stiffness and another is CAP score. And less than 8 liver stiffness is normal, and above 8 we have to go in for other methods of invasive diagnosis of MASLD, which is basically liver biopsy, which is generally in routine clinical practice it's not done. This is a schematic of how to diagnose. If someone has type 2 diabetes, obesity, or one or more cardiometabolic risk factors, and persistently elevated liver enzymes. We do routinely check the liver enzymes, but if it is persistently elevated, then we have to go for the FIB4 scoring. That's a non-invasive method. And if less than 1.3, then either annually or in 3 years interval, we can check. If we get between 1.3 to 2.6, and in fibroscan, if we get score or liver stiffness is less than 8, then again we need to modify the modifiable risk factors, weight loss, diet, exercise, all those sort of things, and then we need to screen them. If the liver stiffness is above 8, then we have to go for invasive screening also, where the gastroenterologists have to be have to come into the picture. That was about the scoring or diagnosing, but mainstay of treatment is the weight loss, which is very much effective for decreasing the liver fat. And 30-minute exercise a day, recommended. If someone can do more, it's more welcome. And it has to be some modality of exercise which will cause weight loss. Not just a simple 30-minute walk may not be enough to cause weight loss. Generally, weight loss happens, or fat, burning is there once we walk more than 1 hour. Less than that, generally, fat burning is not there. Healthy diet definitely has to be there. Smoking is another thing which needs to be stopped. We need to maintain a healthy weight and good sleep. You can see that for fatty liver disease or MASLD to improve, if someone is able to do weight loss of more than 10% to 15%, then definitely that's the best way of doing the reversing the fibrosis. But unluckily, if you see that, if you look into the weight loss maintained in a period of 1 year, it's less than 10%. So that's the most difficult part. And then comes different drugs which have been used for diabetes. There are a lot of drugs which are used and may be beneficial for MASLD, but currently one of the molecule which is originated from Gujarat, saroglitazar, saro means good, and that has a unique mechanism of tackling both PPR, alpha and gamma agonism, and by virtue of alpha agonism, they reduce the triglycerides and the various dyslipidemias and anti-inflammatory effect, and PPR gamma agonism will cause reduction in the insulin resistance and benefiting the glucose control also. So it's one of the drugs which have been recently approved, and it's used for fatty liver disease also. There are other drugs, off-label drugs, which have been used, like pioglitazone is used, but AASLD recommends that it can be used in biopsy-proven NASH, but I'll say saroglitazar will be better than pioglitazone because it has both alpha and gamma agonism. And off-label other drugs are also used. GLP-1 has been used in many of the studies, have shown better results, but it's not kind of approved drug for fatty liver disease. So saroglitazar recently has been accepted as a drug for fatty liver disease by Lipid Association India, RSSDI 2022, INASL, CSI. All these organizations have endorsed saroglitazar can be used in managing fatty liver disease also. So what I'll say is that concluding remark will be MASLD, type 2 diabetes and cardiovascular disease is one thing which is interlinked, and majorly it is caused because of the insulin resistance, and to break the insulin resistance we have to adopt healthy lifestyle and do weight loss, and there are drugs which can be used to aid to that, but it has to be a thing, the patient has to be encouraged to do weight loss by adopting natural methods, not just rely on drugs. Thank you so much.